exciting. This is like a, well, okay, I'm Sarah Schmidt. I'm the president and CEO of the Colorado Health Institute, and I'm really excited to welcome our in-person audience and our virtual audience who is joining us from maybe around the country, because this is an important topic for all of us. Welcome to CHI's monthly webinar series that we are calling Eggheads. We're doing something different today for the first time ever. We have an in-person audience here, which obviously looking at wonderful people in the room today, but we also are joined by our virtual team and our virtual colleagues. So great to have everybody with us for this important conversation. Just some housekeeping. We will have time for question and answer, and so we won't be using slides, but we will be having some conversation and then time for Q&A, both folks in the room and online. So if you're in the room, you can ask your questions live, so just jot them down. We'll get to that time later in the day. And then if you are virtual, please use the chat or the Q&A function, because we won't be able to loop you in for audio to ask your question directly. So we have a team of CHIers who are keeping track of all of that. If you have not connected with the Colorado Health Institute before, if this is your first time, we are a nonprofit mission-driven public health institute. Since 2002, we have been advancing equity and well-being in our communities through our deep expertise and our implementational know-how. And part of that work is convening with partners, and that's what we are doing here today with some of our partner organizations and leaders within our organization. So we're excited for this opportunity. Our topic today is on firearms and firearm violence and death prevention. Some of you may have already seen a report that was released yesterday, 2 days ago, on Tuesday, that was authored. Oh, can I speak up? Yes, sorry, everyone. Learning as we go. The report was authored by Trailhead Institute. We'll hear more about Trailhead in just a minute, but Wellstone Collaborative Strategies, Jacob Bornstein, who's not able to be with us today. That was a summary of a roundtable conversation that was hosted by the Colorado Department of Public Health and Environment, Trailhead Institute, and supported by other partners across the state that we'll hear more about. The report is called Colorado's Public Health Roundtable on Firearm-Related Violence Prevention. We will put a link in the chat if you are online, and if you are in the room, let's make sure that we connect with you so that you can find out how to access this report if you haven't seen it yet. I do want to give a special shout out to my colleague Alyssa, who is here in the room today. She did do some analysis putting the report together. Thank you, Alyssa, for that. So that's what we're going to talk about. It's a new topic for CHI in this context. So I'm excited that we will have the opportunity to learn from one another. And I want to just share an invitation for everyone today, both in the room and online. We are likely here because we have a personal story, or we have something personal that makes us care about this issue, that wants us to have this conversation, and that wants us to think about ways to move forward differently. And I would invite you to hold on to that personal story and really think about what that means for you. I will also invite you to hold on to the Colorado story as well, and the stories that are happening across our communities, across our state, because that's also what we're here today to talk about, thinking about how we can make change as a state. Just for some context to level set for everyone, in Colorado, firearms are the leading cause of death in 4 areas: suicide, targeted and mass shootings, domestic violence, and community violence. Did I get that correct? And then in 2021, where we have most recent data that is shared in the report, there were 1,059 Coloradans who lost their lives due to firearms. And the majority of those were related to suicide, death by suicide, about 70%. So we share that just to give you a little bit of Colorado context, to also hold that with your personal context as well too, and the personal stories that we have that we may certainly influence why we do what we do. With that, I want to pivot and invite our panelists to kick us off here and share a little bit about their experiences at the roundtable, the findings of the report. I did get to attend the roundtable. It was amazing. It was hard. There were hard conversations, but they were really different and hopeful. And that felt really powerful. Yeah. So with that, three wonderful people joining us today. I'm going to start at the end. Dr. Vincent Collins, who is a child and adolescent psychiatrist, saxophone player, a board member of CHI. So very grateful to have with us. Thank you.
Delighted to be here.
Jonathan McMillan, the director of the Office of Gun Violence Prevention with the Colorado Department of Public Health and Environment. And Sarah Lampe, the executive director and president of the Trailhead Institute, another public health institute, one of our sister organizations here in Colorado. So I think Jonathan and Sarah are going to share with us a little bit about the report and what they did and what they found.
Sure, I'll kick us off and then you can go.
Okay.
So the roundtable, the report is really based on what occurred at the roundtable event, which happened June 5th and 6th of this year at the Cheyenne Mountain Resort in Colorado Springs. We planned gotcha. Okay, gotta speak up. Project my voice. Here ya. So we spent about 5 months planning the roundtable event, and Jonathan will give some background that led into the event itself. But we spent time with a committed group of folks across the state, a planning committee, as we name in the report itself, who helped us plan and determine how we were going to set out for these 2 days. The 2 days were really centered around the public health approach. We have often heard when we have violent events or other events related to firearms, well, we need to take a public health approach to address this issue. And we hadn't really taken the time to understand, well, what is the public health approach in Colorado to really address this issue? So we took the 4 steps of a public health approach and planned the agenda accordingly. So the first step is really to look at what does the data say about the issue at hand. So we spent the morning of the first day with a panel of researchers and other experts talking about what is the data that we know, but also most importantly, what data do we not know? This work in this field is still quite much in its infancy of understanding, and so data is lacking. So we had a lot of conversations around what data is missing. How do we know what data is missing given the great dearth of data that exists right now? And then from that panel, we spent the remainder of the time, most of the remainder of the time, in breakout groups around the 4 primary violent type for firearms. So as Sarah mentioned, suicide, community violence, mass and targeted violence, and domestic violence. And in those groups, we started first by understanding what are the risk factors and protective factors. So what are the risk factors that a person or a community might have that might lend itself for them to be more likely to experience firearm injury and death? And then we spent some time talking also about, well, what are the protective factors? What are the things that might minimize the risk of that exposure to firearm violence? Then we were able to, in those spaces, have conversations around, what are the experiences of those in the room? We had a broad array of folks who were a part of it, experts from researchers, experts in the field of public health, as well as community-based experts, community-based organizations who had both firsthand and community-based experience in both preventing and experiencing firearm-related death and injury. Then we spent the next portion of our time looking at, well, what are the strategies that we can actually start putting in place to address these different types of firearm-related injury and death? Most of that time, we also spent not just in, well, a broad, brainstorming of what are the possible strategies, but we actually spent quite a bit of time walking through different strategies by, root cause, prevention, all the way to how are we actually preventing firearms in a response or in a recovery situation after someone might have experienced exposure to firearm injury and death. So we spent a lot of time kind of walking through and understanding from the experience and expertise in the room, how is it that we can address and really look at how do we address and build those strategies across those different violence types. And then we ended our time together really talking through and walking through what are the commitments that we can take to move this forward. So the fourth step of the public health approach is scaling and evaluating and ensuring that you are scaling any of the proven strategies across the communities and across populations. And we really walked through the first 3 steps and then took that last step to say, well, what now? How do we take these ideas and strategies and move them into scalable action across the state of Colorado? And so the report does a great job of kind of spelling out exactly what was discussed in those conversations, what experts brought to the table, and then also talks a little bit about, well, what is next and how do we move ourselves forward in this conversation? So that kind of lays out how the roundtable went, and really that is how the report is also laid out, is to take and look at what were those conversations, how were we looking at this, and then how are we really looking at the public health approach to this topic across the state of Colorado. What would you add?
Oh, boy, I don't know, because that was pretty comprehensive and thorough. Just a few things. So the Office of Gun Violence Prevention is still relatively new. And I've only been in this role just a little over a year and a half now. And the legislation that created the office, and if you have a chance, you can look at the legislation. It's pretty prescriptive about what the role of the Office of Gun Violence Prevention is. And we had 3 directives, which I spent the majority of my first year implementing what the legislation requested. One of the main reasons that I applied and was interested in taking this job was because it was housed within Colorado Department of Public Health and Environment. By lived experience in some training, I am a advocate for a public health approach towards violence prevention. I've spent years doing youth violence prevention, gang violence prevention, and understanding that it's not just there's not one singular solution. It's not just law enforcement. It's not just education. A public health approach requires collaboration from multiple community partners. And the Office of Gun Violence Prevention being housed in Public Health and Environment really excited me, because it's like, okay, now we are taking a public health approach towards one of the biggest issues in Colorado. But the legislation didn't actually reflect that. And so shortly after I went into work for CDPHE in the Office of Gun Violence Prevention, I had the pleasure of meeting Sarah. She called me up and said, hey, Trailhead was doing some of this work 2019, meeting with some of the professionals and clinicians around what is a public health approach for gun violence prevention. I said, well, that's actually what I've been asking myself. So this is exciting. But of course, 2019 was right before the pandemic. So all of those people who were working on the solutions were drawn away to dealing with a global pandemic and how it affected Colorado. So to fast forward, once I got the requirements of the legislation, at least in motion, one of the first phone calls I made was looped back to Sarah and saying, hey, remember that conversation we had about bringing people together to define a public health approach to gun violence prevention? Are you ready? And she said, sure. What timeline you're looking at? I said, this was probably late January. I said, can we do it by June? And Sarah said yes. And a great partnership was forged between Sarah, the Trailhead Institute, the Office of Gun Violence Prevention. We were really intentional about bringing, and I don't want to say the right people together, because there's anyone who really is committed to being a part of the solution is the right person or the right organization. However, foundationally, in order to build what we are envisioning, we needed to have people who were in the room, regardless of what their scope of work was, whether it's academic, clinicians, community-based organizations, philanthropy, that they at least had a fundamental basic understanding of what that public health approach means, what the scientific method is, understanding what the issue is, understanding risk factors, protective factors, root causes, strategies, and then scaling those strategies, evaluating and scaling what's working. And so we spent many weeks going through Rolodexes. I don't know if that's a thing anymore.
Sure.
But going through our networks to identify people who have worked with anyone on the planning committee in the capacity of violence prevention, whether it was suicide, community violence, domestic violence, and doing a deep dive and looking for facilitators who were skillful in understanding best practices, not in just facilitation, but in helping people connect across ideological and philosophical differences. Because even as we did the breakout rooms, one of the things that we encouraged is, let's say Vince here is an expert in suicide prevention, and Sarah's an expert in community-based violence. We didn't want them to go to the breakout rooms of their expertise. We actually encouraged the suicide prevention expert to go to the community violence, and the community violence person to go to maybe it's domestic violence or suicide prevention, because we wanted that cross-pollination of expertise where people could bring their expertise and their subject matter and learn from other people who are experts in those spaces. So that, as you'll see in the report, we have laid out what are some of the cross-cutting risk factors, protective factors, and strategies, with the hope of identifying where can we all lean in and collaborate, or where those collaborations already exist, and we can build upon that momentum of resources and expertise. So I'm beyond excited at this point, because if nothing else, as I mentioned, the legislation that created the office didn't have a lot of public health written into the black and white letter of the law. Now we have a roadmap of what the work for the Office of Gun Violence Prevention, and not just the Office of Gun Violence Prevention, but for all of Colorado, anyone who wants to play a role can now participate in next steps as we build this out. And with at least my vision of creating something that future generations of legislators, educators, clinicians, community-based organizations, even parents can use in order to create a state and hopefully scale it to a nation where people are feeling hopeful that they won't ever be involved or impacted by gun violence or firearm violence.
Thank you, Sarah. Okay, want to just invite folks in the room and then our virtual audience. If you have some questions, please jot them down or send them in by chat or Q&A. I have some of my questions for our delightful panelists that I'm going to start with, if that's okay. Vince, I would like to start with you, if I can. You are a clinician. You've been working with young people and families for many, many years. In the report, behavioral health is all over, from prevention and primary prevention and root prevention, all the way through this. Sarah mentioned how to think about recovery on the other side, whether it be workforce, whether it be programs, whether it be access to culturally relevant services. Would love to just, can you share with us a little bit as a clinician, what you see as some of the opportunities, maybe some of the challenges for really bringing in these behavioral health approaches as we're thinking about reducing firearm violence?
That really gets to the heart of it. I'm delighted to give it my best shot. It does occur to me that since 2012, after the Sandy Hook shooting, there was a shift in the conversation that was taking place in professional circles, but also among the lay public. What became concretized is the notion that people who suffer from mental illness are disproportionately involved in gun violence. And that the logical answer to this dilemma is to increase the number, the availability, maybe the tools that we clinicians have at our disposal in order to work with those people, not only for the benefit of the people who would engage in violence, but also for the benefit of the rest of us who suffer, when there is a targeted mass shooting. So the conversation became quite shrill. Those psychiatrists and psychologists need to step up and take care of those of us who are struggling from mental illness. It's more complicated than it appears on the surface. And I thought it might be helpful to look at each one of these 4 groups. And I do want to applaud that simple notion of breaking out that amorphous and huge population of people who engage in gun violence into those 4 discrete categories, with the understanding that there are likely to be additional categories in the future. But those 4 are very, very helpful. We mental health professionals have the most experience with people who fall into the suicide category, and that probably doesn't come as a surprise. What frankly did come as a surprise to me is the notion that 70% of the people who die from gunfire are suicidal, are the victims of suicide. To answer the part of the question about what works and what doesn't, what works is when a youngster comes to a facility, let's call it, I don't know, Denver Health Hospital, for example. And he or she has concluded that despite tremendous ambivalence, they recognize the need to address this pervasive sense of hopelessness and helplessness. They recognize that they are terrified, that they know where the gun is, they know where the ammunition is, and they're afraid that they're going to act on it. They've overcome the shame of identifying the family as somebody who has a young who's suicidal. They're tired of covering up the lacerations on their arms and legs. And they've concluded, yes, I need some help. They have the good fortune of meeting with a psychiatrist with whom they establish a rapport, somebody who they can share some of their deepest secrets with. They also have the opportunity to work in the context of family therapy. So there are family therapists on this inpatient unit, on this hypothetical inpatient unit, who can help them to identify that it's when dad has been drinking that they become most despondent. There is an opportunity to meet with a psychologist who identifies that there is a very subtle but present learning disability. There's a slowing of the auditory processing. So when you think the child is understanding, they're not understanding, they recognize they're not understanding, and that heightens the despondency. So when it all works, there is nothing more exhilarating for those of us who are engaged in this kind of work. You recognize that the child is able to see that they have auditory processing problems, able to talk with the father about his drinking, able to connect with the psychiatrist. There are arrangements made at the end of the hospital stay so that there is a seamless flow to the outpatient side of the operation. That's when it works. I don't think this looks like I'm preaching to the choir. It won't surprise you to learn that often it doesn't work, and often insurance calls and says, "You've got 2 more days to work with this child, so come on, get a move on. We've been reading your progress notes, and this youngster has not said that they are actively suicidal. Wrap things up. You need to move." On the other hand, it also doesn't work when the child does not disclose that they have been drinking. It doesn't work when the therapist and child can't establish a rapport. for reasons that we often don't understand. It doesn't work when the family is not engaged in therapy, or when they come to the family therapy session, somebody's been drinking. It doesn't work when there is no seamless transfer of the patient to the outpatient side. And that's huge. There's a 3-4 month waiting list. And all hell can break loose over the course of those 3 or 4 months. So there are some institutional barriers that get in the way of us being able to, in a dramatic way, impact that horrific figure, 70%. There is obviously work to be done. I thought the second category that might be interesting to talk about are the targeted mass killings that take place as a result of firearm violence. In my capacity as the child psychiatrist of record at Denver Health, it was not unusual for us to get a referral from the public school system. And the referral usually was precipitated by the fact that one of our school-based counselors identified that this youngster has a map in his or her, usually his backpack, of the exits and the layout of the school. And there is a list of people who need to be killed. So when the school-based counselor identifies that there is a potential risk to the kids in that school, we get a phone. I've been out of practice now for 8 years, but we would get a phone call saying that we have an admission. We would admit the child and we'd begin the hard work of determining whether or not that risk was real or not. And that was probably the most terrifying assignment because you don't want to get this wrong. Predicting violence is difficult under the best of circumstances. Over and over again, you will hear me say that the stigma is huge. Inevitably, we would discover that the child was being bullied, and that his fantasy about retribution was the result of having been bullied. When it worked well, insurance would give us enough time to complete the evaluation. The parents would become actively involved. The principal would recognize, okay, we've got to do things differently on the playground because this child is being bullied. And once again, these are recurring themes. If you could arrange for seamless flow to the outpatient side of the operation, things would work more smoothly. Statistically speaking, we do a better job. I've really struggled with what I'm about to say. We do a better job identifying kids who will not be violent than we do identifying people who will be violent. And that's a little bit of a paradox, but there's a lot of false negatives. So and our record is unblemished at Denver Health, that we've identified that these youngsters are not representing a risk, assuming that we can meaningfully address the issues that led to the risk in the first place. The numbers are small, as the report suggests. The impact is enormous and has a profound series of profound ramifications for those of us who are trying to go to the movie theater and want to be reassured that we're going to arrive home safely that evening, or who want to send our kids and grandkids to school and not worry about the mayhem that may ensue over lunch hour. So although the numbers are small, the impact is huge. Third category is domestic violence. And what's interesting to me is that on the adolescent inpatient unit and on the adult unit, we would invite patients at the time of intake to talk about the nature of their intimate relationships. And the number of people who identified that as a key part of the problem is vanishingly small, which baffled us. because we knew that the statistics would suggest otherwise. I think the shame of being part of a relationship where you are being mistreated, but you can't quite bring yourself to leave, is huge and gets in the way of people being able to raise that as an issue that needs to be addressed in an inpatient setting. I do have a sister who built a career in Oklahoma as a clinician who worked with victims of domestic violence. And she echoes my concern that I can't get these people to talk about it, even when there is obvious evidence of a facial bruise, for example. And one of the things that I look forward to in the next town hall meeting is trying to figure out how we make people more comfortable addressing that issue. The fourth is the community violence. And if I may, I want to share with you my personal experience of working on an adolescent inpatient correctional facility when I first arrived in Denver in 2006. This was specifically for female incarcerated people, 85% of whom described their experience of having been physically and or sexually abused in the context of the family. The literature would suggest that there are risk factors involved in people who engage in this kind of violence. And I don't think I'm telling you anything you don't already know. Often from communities with a lower socioeconomic status, where economic opportunities are not apparent to anyone. There is family dysfunction much of the time, with disciplinary measures that are inconsistent and often unnecessarily harsh. There is overt, physical and sexual abuse of kids. There is a higher incidence of transience in the neighborhood, so there is no solid sense of community. And these are gross over generalizations, and there are youngsters and adults who don't fit into this pattern, but those are the kinds of structural impediments that we have when we're trying to address their sense of rage, coupled with social isolation, that results in the solution being picking up a gun. So those are my.
Yeah, thank you.
That's my assessment as somebody who's been doing this for way too many decades, about what works and what doesn't work. I think one additional plug, though, for this report is that much of this information needs to be disseminated to those of us who are providers, because it assists in thinking about next steps.
Thank you, Vince. I think you really thoughtfully identified some of those structural forces that are really influencing our individual behaviors and really shaping our communities. So I appreciate it. I want to ask Sarah or Jonathan, the report does really focus on community-based approaches. It is very grounded in community and has a particular approach, which is of course in alignment with the public health approach, around how to engage all who need to come together to implement, identify some of these issues and start to make some changes. It doesn't say big P policy isn't a part of that. Jonathan, as you mentioned, we need a lot of things. It's not one thing, but it's very squarely focused on community and engaging community and community-based solutions. And it presents, it feels like a little bit of a reframe in terms of a focus away perhaps from some of the policy type, big P policy type solutions to taking some different ways forward. And I would just love to hear one or both of you sort of react to that, or how does that land for you? What do you think the opportunity is there? Why this new way?
I just love how Sarah just asked me.
I know. Not, is it?
So I'll start here with Sarah, yes, that.
And they're young, we need to be louder.
Okay.
Sorry. All of us are guilty up here.
Okay. I use my parent voice. You know, I come from, so, just very transparently, I grew up here in Northeast Denver. And I've gone on a transformative journey, from being involved in gang violence in street gangs and whatnot to now being here as the director of the Office of Gun Violence Prevention. And I can adamantly say that a huge part of my success was being surrounded by my community and people who were really invested in transformative change at the individual level. Like I think of Reverend Leon Kelly and Open Door Youth Alternatives right down the street here, right? To community change. And that's, you know, those are the people who are driving community work or leading community driven work, based organizations. Regardless if they get support from the state of Colorado, from a public health institute, from philanthropy, whatever it is, they're still going to be doing the work. They're the ones who are the subject matter experts because they're the closest to the issue. They know the root causes, they know the protective factors, they know the risk factors, and they are working diligently to come up with strategies and drive strategies towards transformative, I would say a paradoxical change. But they don't necessarily get the support that is necessary because the conversation tends to get muddied with I want to say something maybe even a bit controversial with people who are coming from the outside and say, oh, we have a solution. We have a lobby who's raising hundreds of thousands, if not millions of dollars towards advocating for, again, kind of prescriptive policies that we believe are going to drive change however we see it. And the community-based organizations are often left out of those conversations. They're not the ones informing what that big P policy that we should be pushing and lobbying for at the Capitol and other places. So that was a very roundabout way of saying that my lived experience and my love for community-based work really is informing the way that I hopefully am leading in the direction of the Office of Gun Violence Prevention, which then leads back to the conversation that I had with Sarah once I had got hired about understanding what the public health approach is and making sure that even when we talk about public health approach, we're not just talking about the academics and clinicians who have public health in their names or letters behind their names, right? We're actually including those subject matter experts who are doing youth violence prevention, gang violence prevention, domestic violence prevention, suicide prevention for teens, for our elders, for our veterans, people who will probably never step foot into an official office of public health ever. It's all about they're going to those community-based organizations who frankly are often struggling to find the resources to keep their doors open to provide those real-time services.
What I would add to which, you know, I don't know how much to add because you did such a beautiful job, is I think Vince did a great job of describing a lot of the issues really lie in some root cause aspects of what is happening in community. How do we support community in order to really address and really prevent any further firearm related injury and death before we even get to a place of a young person walking through a door. And so to me, a lot of the reframe of the community-based approaches is one, centered in prevention, really centered in how do we start really looking at what is the root cause of this and how are we preventing it from the start. And then the other piece to me is I really think that, and Jonathan, you put it very well, like community is where a lot of work is happening. And it also is where a lot of the innovation and creativity towards finding a solution is rooted. And I think if we continue to not look at community solutions, we will lose that sight of and lose out on some really beautiful, innovative, and creative ways to address this issue that without community, without folks who are living this every day and experiencing it and trying multitude of different things, failing and learning and knowing what is working on the ground, without that, we will miss out on some really creative, really beautiful, and really amazing ways that we as a state can move forward and really spread the word of those creativity and innovative things that are happening in community every single day. I think this report and the roundtable was really meant to say, how are we providing a space and a place for those kind of really awesome things to find, to get root and grow in a field that really is so new. What I don't want is the newness of the places that we are now to lose sight of what is possible and what could be a really great approach to really addressing this issue across the state.
I'm intrigued by what you, at the risk of stating the obvious, again. What you are both very politely suggesting is that by the time they get to us, it's already too late. And we are so siloed and so busy that we don't have an opportunity to engage with community-based resources. We're frantically running around putting out fires and then shoving folks out the door. So this is intriguing to me.
You know, in my experience of being a professional, of a case manager, outreach worker, working hand in hand with the young people who are oftentimes most at risk of being involved in gun violence. We're talking about active gang members or people who are living active in communities that have gang or violence within. One of the best strategies that I was ever introduced to was what they call the comprehensive gang model, right? And this is a model of violence intervention that comes out of DCJ, with the National Gang Center. I had the benefit of sitting at tables, the multidisciplinary teams, to review the cases, literally case management, with professionals from Denver Health, with professionals from Human Services, with law enforcement and probation and the halfway houses and behavioral health and all of these different partners around the table, literally looking at a case of a young person who, for whatever reason, had gotten onto my caseload. And that model worked magnificently because with my connections to community-based, what we would call behavioral health providers, it may just be a mentor that running a community-based organization that focuses specifically on young Black men. And they're talking about mental health and identity and goal setting and all of these things that academically we could put labels on, like sociology and behavioral health and all of these things. They're not getting it through that lens, but it's also paired with the actual clinical behavioral health. And I was that connecting factor to bring those two worlds together to impact this young person's life. You know, community-based organization that may provide services for the family, helping mom find a job or develop skills, helping dad get a job, whatever is necessary in the family. That could be, and they're meeting once a week, just to discuss how did the week go. But there's not I'm messing up the initials, a licensed social worker, right, involved in that. It's actually the guy who went to prison and understands that family is a important part of primary, secondary, and prevention and intervention. So that was a long ramble to say that my hope is that we are able to replicate that model as we talk about the totality of public health approach to gun violence prevention, right? Regardless of if it's community violence, suicide, domestic violence, even I'll attempt to wrap this up here. One of the things that really got me excited about the facilitator for the domestic violence breakout group is a young man by the name of Derek McCoy. And Derek runs a organization called Project PAVE. Is it Project PAVE? Okay, okay. There's a Project Proud, and I conflate the two. Project PAVE, that works with young men to help them be healthy, viable men and embrace what masculinity, the totality of masculinity looks like. And that's very much upstream gun violence prevention, because we know that the majority of perpetrators and victims of firearm related injuries and deaths are men. And we're looking at addressing their mental health, their spiritual health, their physical health, their financial health, and all of the different contributing factors of whether a young man is going to make a decision to pick up a firearm to harm himself or others, right? And I lost my point there, so I'll shut up.
Well, and also to talk, Vince, to your point, I'm recalling a conversation that Jonathan and I had early on in the planning around, it may have been more than just you and I just remember you and I in this conversation around like, are we going to talk about, firearm related death and injury more than just prevention? Like, are we going to focus in prevention? Or are we going to talk about the full spectrum of all of the things? Which, gets unruly, it gets hard. I think we've landed in a good spot. But what we did talk about was when we think about strategies from root cause all the way through to recovery after an event, or even preparedness for the inevitability of an event that might happen, all of it has aspects of prevention in it. All of it has pieces and parts of what are we doing in the recovery space to ensure that we are doing everything we can to prevent another another firearm related death or injury to happen. And so yes, there are aspects of, if we really want to get at prevention, we want to start in communities, start with families, start in the way to prevent it from even happening in the first place. But we also have an opportunity of, when you have someone who comes into this pretend hospital of Denver Health has had experience of domestic violence, has had experience of exposure to violence in the home, in the community, in school, there is an opportunity to work with them and prevent them from furthering any sort of violent act themselves that could then also have a ripple effect on others. So I think for me, there is prevention in all of it, and it's not too late when they walk in your door. You play an important role. I think all of our clinical behavioral health providers play an incredibly important role of ensuring that we don't have that cycle start over again. So no, I don't think we're saying that it's too late. I think it's on a spectrum of possibilities.
Okay.
Just real quick, I want to say, there's also a model of hospital-based intervention, right? Which is gaining more and more popularity. In Denver, we actually have one of the national models with GRASS, the Gang Rescue and Support Project. And the subsidiary of that is AIM, and always at-risk intervention mentoring, I think it is, where there's outreach workers with lived experience in gangs and violence who are showing up at the hospital beds, host a young person who has been involved in violence. So there's that part.
Yeah. Okay, I'm gonna hold my last question because we're not being nice to everyone in the audience to allow them to ask questions. Any of our in-person, yes, you're on.
Wonderful, thank you. I want to say first of all, how grateful I am to have the opportunity to come talk to you all about this today. Dr. Collins, what you were saying about the four different aspects of this report, what I heard you say over and over again was family. And Jonathan, I also heard you say family. I'm a couple and family therapist in addition to being a faculty member here locally in Colorado. And what is so compelling to me that I hadn't quite connected the dots was that in doing family therapy, in many ways, I am doing gun prevention work. But it then occurred to me, why have I not made that connection before? And I think in some ways we have, in the big picture, what we often will do is sideline families, because it feels so familiar to us. We all have families, it's so connected. So it's not centered often in our discussions of violence. Or centered in our discussion of behavioral health. As a family therapist, even within the profession of behavioral health, family therapy can be kind of sidelined. So I just am so happy to hear all of you mention families. And I would just recommend that you think about how are families, what's the role of families, and what does the prevention actually look like in terms of helping families? What are the action steps related to families or supporting family therapists who are doing that?
I'm very glad that you mentioned that. It's fascinating to me that that's the dynamic because, and again, I will say this as a disclaimer, I am not a licensed therapist, I'm not a social worker, I'm just a person who is very passionate about understanding, again, the public health approach towards things. Like if we look at the adverse childhood experiences, how many times does family, do young people or a person experience one of those ACEs within the family structure, right? And the more ACEs that a person experiences, the more likely they are to experience violence or be a perpetrator of violence in their life. So it's felt like a duh moment, but it doesn't come across that way. The other piece I want to add to this is, during my time, my previous role, previous to working at the state, I had the opportunity and the pleasure of being the director of the Office of Youth Violence Prevention for the city and county of Denver. And the young people, I had a youth council, a youth advisory council. They understood exactly what you're saying is everybody has a role to play in gun violence prevention, whether they recognize it or not. And they actually came up with a model for how the city and county of Denver is moving forward with youth violence prevention. Safety starts with me. And I have borrowed that in my philosophy of having conversations with people at philanthropic organizations, with people who are in procurement at the state level, understanding that if you are making it more difficult for a community-based organization to get a contract to do services, that could be the difference between running a program at Friday night that a young person will have a safe place to go to have a caring, trusted adult that will connect with them, or catching a bullet. Right? We all have a role to play in gun violence and firearm injury and death prevention.
What I would say in addition to that is I think and I'm gonna go into the very public healthy side of things, but we are really lacking a lot of data and understanding of the family experience and an understanding of how that does impact eventual outcomes. And to me, part of that is because we lean ourselves so heavily into the quantitative aspect of the data. And I think a lot of where we will find the data around family experiences in qualitative data and the understanding of the qualitative, that is where the stories are, that is where the experience exists, because I think the family experience, there might be some aspects that are common, but there are also so much uniqueness in what each family experience might be. And those qualitative data pieces are where that experience can come out, that uniqueness and that differentiation of understanding of that family experience. So to me, I think it also will require us to lean more into the qualitative data and lean more into that area of our world that we have not traditionally and typically worked in, and will provide for us the unique and diverse ways and approaches to look at the family experience.
Should we take maybe one question from the virtual audience?
Yeah,
Okay.
got a couple of questions related from the virtual audience, and no surprise, they love data. So one of the first questions we have here from Thomas: what systems are in place to collect data related to incidents of gun violence? Who analyzes it, and for what purposes? And what barriers do we need to overcome in that?
As the CDPHE employee, there's the violent death reporting system that exists at the national level, which records and it records every death that is classified as violent, and understanding that that may be through homicide and or suicide. Right? And I hate that there is an and or in that, but and then the data can be broken down by what the weapon was. It's stabbing, choking, and then of course firearms. I don't have the website at the top of mind right now, and I don't remember all of the rest of that question, but I can plug that you can link to, at least for Colorado, you can link to that data at cdphe.gov, and you will link out to the suicide and homicide reporting. Who all is capturing that data? A lot of it's going to come from law enforcement. A lot of it's going to come from our medical facilities who are treating those incidents, coroner reports from all across the country, and the different medical examiners. And then just very quickly, one of the prescriptive directives of my office was to build out a resource bank, which hopefully will be coming out any day now. Everybody cross your fingers with me. That's a partnership with the Colorado School of Public Health. My office is partnered with the Colorado School of Public Health to launch this resource bank, which will be a very user-friendly, interactive platform where anyone can access those data. And I will be, once we get it initially launched, we'll be looking at adding in more data sets, like capturing information from paramedics, to have more real-time understanding of where the incidents are happening. Maybe from where they're happening, we can have a better understanding of what the root causes of the incidents are. So working on all of that.
I'm looking at the people in charge. Do we have time for one more question?
Yes, do you want to take it from the room? I do have more online questions.
Let's take one from the room. Yes.
Hi, thank you. I think the roundtable and the report are really great foundational building blocks. And I'd just like to hear a little bit more about what are the next steps? Where do we go from here with what seems like pretty clear alignment around strategies?
Well, I'll start by saying we've said all along that the roundtable was step one of, like, I don't know, 875.
Yeah.
I think the number gets bigger every time I say it. And really, this report is step two of that, right? The intention of this was to say, how are we pulling together folks in a way that ensures that we are taking action beyond this? So the first step for us was to have follow through and to say the roundtable is not gonna be a one-time thing, it is step one. And so really what we have done is we have followed up with all of the attendees. They actually did a lot of vetting of the report before it was released. We continue to follow up with them. There was, at the end of the roundtable, we had a half sheet of paper of like, what are you committing to do beyond this roundtable, and what is needed for you to do that? So in the report, it very clearly outlines some of the things that we heard from those attendees of what is needed. What is needed? We need we need funding in communities to be able to do this work. Jonathan described that very clearly earlier around, if we are going to have community-based work happen, they need resources for that to happen, not just policy. We need funding, we need funding to be able to very clearly address and put in place strategies that the communities have identified and understand for themselves. So this state-based understanding with the state-based data is one step, but for them to be able to look at their own data in their communities and identify where their priorities are and really take steps for those priorities to take place. Those are some of the really some of the things that we'd like to see happening, is saying, how do we support and provide resource to those communities to be able to take those next steps? And also to be able to provide ongoing statewide structures for those communities, whoever might need to be taking those actions, to have support, have resources, have technical assistance in places where they need it, have communities of practice where they can come together and share their beautiful creative ideas amongst each other, and also share their feelings and understanding of, okay, this didn't work. What are some of the things we can be doing to improve what is happening? So there are lots of hopeful plan next steps. These are the things that we're working towards. I think we are continually bringing together partners who are part of the roundtable to say, okay, let's keep this momentum going, and how are we maintaining that? Jonathan's office is a huge part of that. I think the Office of Gun Violence Prevention, the fact that it sits at the State Health Department, the fact that it exists, the fact that we have someone as passionate as Jonathan in it, really helps us ensure that we have some accountability for that to happen. And we, as a Trailhead Institute, as an organization, have committed to saying we are accountable to make sure that this step one, step two are not the end of this conversation. How are we maintaining and continuing that conversation? And I know Jonathan has already talked about the resource bank coming out. That is some additional action that's happening. They have community grants that will be coming out as well to be able to start some of that community funding, but hopefully it's just the start, that we get additional funding and support to be able to keep this work moving.
The only thing I would add to that is that keeping in alignment with the public health approach is identifying who wasn't present at the roundtable and being very intentional. When I say who, is not necessarily just individuals, but it's even I hate to say it this way, categories of people. We need more philanthropy and probably very specific philanthropy work groups. We need law enforcement. We need the judicial system. We need community-based organizations who may not have had that foundational public health understanding that I talked about, which was essentially a requirement for the first roundtable. Now that we have a report that lays that out, and hopefully people are looking at that, bring them into the conversation to say, okay, you do great work. How do you see yourself playing a role in this public health approach, and building that out? And so even as I talk about it, youth, we were missing youth and it broke my heart that we were not able to get more youth in June at the roundtable, but it was also June, and I mean, they were having fun in summer. They didn't want to spend a couple of days with a bunch of old folks. So, but being very intentional about bringing youth and the subject and the expertise that they bring to the table, and helping and having them help us build this out, so that, again, we realize, hopefully, again, my vision of creating a product that is a primer or a starting point for creating a violence-free Colorado.
I know we are at time. Please join me in thanking everyone. Okay. Please do read this report if you have not. Please read it. Please find one thing you can do, one conversation you can have, something in here that you can take action on. Please stay connected with us through CHI to learn more about what's coming next. We'll be sharing information from these wonderful organizations and keeping everyone informed. I will say this is our last monthly webinar for the year. We're going to take a break to get ready for our annual Hot Issues in Health Conference, which is on December 1st. I think there's probably people putting information in the chat about how you can register for that if you want to join us. But we're going to be refreshing this monthly series to keep things lively. And so stay tuned for more information. Thank you everyone online who's joined us and everybody in the room. Thank you. All right.
Thank you.
Thank you.
It was so cool.
You did it, Brad.
Yeah.